Really? So YouTube's just not playing nice, huh? Okay, so I'm gonna do a little filler here. Just to we're gonna go to about 11, maybe just a little bit short before we break for lunch. We talked a lot about cardiac arrest, and this is something that on our side of it, on the fire side of it, we've drilled quite a bit. We let off over COVID just because that's just what happened with multi-company drills. We tried to keep the stations separate but equal. I'm not sure how well that worked, but that's what we did. So cardiac arrest. Again, it's something that I've worked very closely with our guys. We are, what are we, about 93 people currently, Chief-ish, something like that. We have 15 paramedics. So obviously we rely a lot on everybody in this room for that next level of care. Our goal on the fire side of it is to make sure that we set you guys up for success. If we do our job really, really well, it sets the next stage of, this next level of care up for success for better patient outcomes. So we started tracking some data, and we wanted to know what can we do in the field to better provide quality care for our patients. And so that started with this study right here. This is a great read if you get bored. It's a 426-page document over the from the AHA. Boy, it's a page turner, let me tell you. But there's some great information in there. And so what I came out of it with was a couple of things. And of course, the docs had said it, and they're completely correct. But what came out of that document and some different discussions was for a need for a more seamless integration of patient care or a scripted. If you guys ever see any one of our trucks roll up on a structure fire, the first 3 to 5 minutes kind of look like clockwork, and then it starts to adjust as the incident commander sees what's going on and needs to make changes from there. And so we took that approach from no smiling in the back corner. We took that approach with cardiac arrest, and what I'd like to do is just kind of introduce you guys to it, so if you're running one of our crews. I know you guys run with a lot of different entities, and you get a lot of different levels of service or not service, depending on exactly where you've responded to. And that puts you guys at a disadvantage. Our goal is to make sure that you have the advantage when you're inside the city of Joplin. So what we did is we created this document right here, and we've trained over it several times. This is pit crew CPR. What we wanted to do was standardize the first few minutes of care, and this is really what I kind of wanted you guys to see. So when you go in there, this is what it should look like. Depending on what time you get there with our crews, we drill quite a bit. We have all the feedback stuff. We have the same exact monitors you guys have. Of course, it's probably going to be an AED mode when you get there. Please take it over. Please use it. Please do whatever your SOGs allow. If you need to swap out monitors, I get it. Whatever you need to do. But when you get there, there should be a lot of things happening very, very quickly. We should have people already assigned to the chest. We should have people already assigned to drop an eye gel. How many people like the eye gels? Really? Not too many. I personally love it because that gives me a predominantly EMT provider a somewhat secured airway with capnography and all kinds of other things. I don't have to have my guys stop CPR to drop it, and once it's dropped, I don't have to have them stop CPR to give a breath. And CPR is the only thing that makes a difference. In a room full of ALS providers, we suck. It's CPR that saves them. Just the truth. It's what they 249 pages, or was it more than that? I apologize. But that's what we found. It's CPR that's saving the patient. So we need high quality CPR. And so our guys are preached that. Our goal is to check off some things so you guys can do your job and leave all these other things on the table for somebody else to do, if that made sense. So as we start working together, what I would like to do as we're coming through this next year is actually get our crews out into the South Station, into the Web Station. If it runs with 3, get our crews out to the Main Street Station for Newton County, and work some of these calls together and integrate a little bit better. It's that seamless patient care that provides the outcomes. So again, we try to get somebody. We have a myriad of different responses. We could have a rescue with 2 people. We could have a ladder rescue with 5 people. We could have a myriad of different people. You guys might show up with 2. You might show up with 2 trucks and a battalion chief or something like that. You could show up with 5. But depending on what you get is what we make work. So it's kind of a flex back and forth as far as what happens with our people. But it always bill us before ALS, and we really drill on that. Get that airway secured, get on the chest. If the patient is not somewhere we can adequately provide care for that patient, the first thing I want them to do is grab that patient, go to the living room, go wherever. Some of these little tiny houses, you may have to go to the front yard. I don't know. Go someplace that you can put a large group of people around that patient to provide care. Don't start CPR in the bed, blah, blah, blah. We all know that stuff. But I want you guys to know what's being said on the other side to our providers. So, just to help integrate that. And, I'd like to see some of the feedback. I try to get back with Mr. Prosser and Mr. Powell as, we take the feedback off of our monitors, we download it, and each time one of our providers runs a call or a code, I should have pulled that, they get a report card. Has anybody seen the feedback from the Zoll monitor? I know our guys, I wear them out with it. So anybody else seen that? That's something I want to do real quick. I'm going to grab that real quick just to show you exactly what parameters are being recorded on the Zoll, what you can see, compression depth, time off chest. It's actually pretty interesting. And the guys will pull that information and they'll sit down and do kind of a postcode training where okay, this worked well, this didn't. This guy is a really good compressor. This guy, well, you didn't do very well. When you get a train, you're going too fast. What we found is that fast is shallow. And it's not good compressions. So if you see somebody going too fast, they're also going to be going too shallow, and they're going to have crappy release volume or release velocity. All those matrix put together is what makes high quality CPR. High quality CPR is what saves our patients. So the other side of that was, all right, so now I've convinced the boss that this is a thing and I need to spend some money. And so we did. We invested money. We walked back and forth with different iGels and different things we bought. Rescue pods. How many people use the rescue pod? Ish. It does matter. I know we kind of started out with certain guidelines as far as, certain patients should get the rescue pods, certain patients should not. I'm just be really honest from administrator point, they're $115 a piece now. I bought several over the end of the fiscal year. So I get it. However, that ability to keep the air from rushing back into the lung cavities and make that refill with blood makes a difference. If you can get that on there, I push our crews, get that iGel placed, get a rescue pod on it, and then slow down. The hurry is to get on the chest. Everything else is secondary, a far cry from secondary. Get on the chest, get on the chest, get on the chest. Coordinate. Coordinate the move of the monitor. We need to switch your monitors. Okay, coordinate that with CPR at the 2-minute break as they're giving a breast or they're doing a pulse check. Coordinate the auto pulse. Coordinate the auto pulse. Everybody has their opinion on that. Auto pulse. It needs the straps. If you don't have the straps on it, it's not going to work. The patient's going to move on it. The sensor bar is not going to read. It's not going to work very well. So make sure you have straps. Get your patients on the auto pulse. Coordinate with that with the CPR. Do that at the 2-minute break. Use already designed breaks in that 2 minutes to continue high quality CPR so we continue that perfusion. After we get off the chest, it takes 10 to 15 seconds to rebuild that perfusion back into the bloodstream to the brain. The fight's for the brain tissue. Everything else is doing just fine. Things that we already know. So I'm trying to look over my shoulder here and do 3 things at once. My screen went out, so I'm cheating off these screens over here. So this is what we started right here. This data point started, let's see here. It was in May of 14. We started recording data. We started looking at time out of the house, time on scene, the way we traveled. We started looking at if there was a witnessed arrest, if there was CPR by bystander initiated. Did we use our iGels? Are we using in the field? We had combi tubes forever. I hated combi tubes. I hated them as an EMT, and I hated them for the last 20 years as a paramedic. They suck. So, I want to know, is the iGel going to be the same thing? Is it going to be what grows dust in the bag? And what we found is, we've been using a lot. Let's see here. There's the iGel column right there. We've dropped 54 iGels in the last 18 months. I did hear today on an email that they had an issue with one patient. It didn't work. I'd really like to get with that crew. It happened this last week. It didn't work, and that was kind of the first I've ever heard of that. I've heard of people having to move the tongue out of the way, it being people with fat tongues, stuff like that, or the wrong size. We typically just carry the 3, 4, and 5s, but recently we've come to the full pediatric set. We have the same sizes that you guys have, so we go from 1 all the way to 5 on our trucks. Hopefully we never have to use those. But again, we're starting to use them. We're using them out quite a bit. So all this stuff put together, and I try to track some of the weird data points out there, different risk factors. I try to follow up. If our crews work a code, they'll get an email from me with the report card. They'll get a report from the hospital on what happened in the ER. They'll get the STEMI report from Michelle Wolf or who's the one at emergency. I just went, is it Rita Stiles? And I want to get our crews involved, get them vested in this, and it's worked very well. Our crews are doing very, very well. When I say our crews, I mean everybody in this room, right? Because we're on the same team here. So every one of these blue ones is a save. As we start walking through this, there's a couple things I've noticed. One, cardiac arrest went away when COVID came around. COVID cured cardiac arrest. I'm sure you guys saw it in the field. We just didn't work a lot of codes in May, in June. However, here lately, we're starting to work them again. There's October right there. So I got what, 1, 2, 3, 4, 5, 6, 7, 8, 9-ish, something like that. I counted it quickly. We're starting to run cardiac arrest again. We've already run 2 last couple of days. I haven't been able to chase down those. But what's that mean overall? That's a lot of data points to look at. What that means overall, you guys are doing phenomenal. They can say what they want in the ER about everybody dies, but in the city of Joplin, they don't. If we're responding with Newton County and Mets in the city of Joplin, national average for all arrest is 7.5%. Well, I'm not counting DOAs. I mean, that's not a cardiac arrest. That's a dead person. So I'm counting directly according to the AHA 2018 guidelines, the update. That's a 22% survival rate. If we can get somebody to actually get on the chest, if it was a witnessed arrest with bystander-initiated CPR, it's actually a 40% survival rate, 40% chance at life. That's phenomenal. That is, everybody in this room is working very, very well as an integrated team to make sure that these are happening. So, one, I want you guys to know a couple things. We want to be a part of this. I know for years it's been this, that, and the other, but we definitely want to be a part of the success of the patient, and we're vesting our personnel in that. And two, you guys need to see what's actually going on. You guys are doing a phenomenal job in the field. I know we haven't run a lot of them, and it kind of comes and goes at wanes. I mean, we've had months we've run 15, 16. At the beginning of the year, we were rock stars. I was thinking, man, this is going to be a great year. There's the year break right there, man. The first 10 or so, we're saving people left and right. It was awesome. Again, by 2018 AHA guidelines, when we recognize a crew, it's if the patient actually walked out. Per AHA is, if later on there was a decision to terminate, but they had some type of brain function post resuscitation. Most of those people, they categorize them into patients with deficits and patients with full recovery. But that categorizes everybody. If they still have deficit, it still counts as a save according to AHA. So I just use their numbers as comparison to our numbers. All right, I'm going to pull up this report, from Zoll. I might have to grab my laptop because I can never remember the. Hey, look, the keyboard's now working again. That's great. Intermittently. I know, right? I may have to grab my laptop real quick and plug it to the HDMI, which is fine. The problem is that I save all my passwords. Everybody else do that. You save all your passwords to your device. You go somewhere else, like, yeah, I'm screwed. So type looking sideways. I know, right? Well, it's Joplin. All right. Oh, yeah, I have no idea. All right, I'm gonna grab my laptop real quick. I have it right here. All right. It'll take it just a second to re-recognize, but it'll get going. Yep, here we go. All right, so come on. All right, so here's a bunch of the different matrix. I'm just going to pick one for everybody to see here. This is kind of what the report card that gets emailed out. Again, the whole purpose of this is not getting by. This is quality assurance, right? This is how can we work better on our patient. We actually get a report that does that, and it goes off, obviously. Oh, are you kidding me? I unplugged and I carried it from here to here, and the battery died. I apologize. Obviously, I need to get an updated battery on this one. Yeah, it literally killed it. And all right, so that's going to reboot for just a second. It does pretty good usually, or typically. But it looks at different matrix. It looks at compression depth. It looks at compression rate. It looks at release velocity of the compression itself. If we have that guy that is doing compressions, it's always leaning on the chest, that lack of recoil will not allow the blood to respill into the chest cavity. Come on. And so therefore the next set of compressions is equally poor, and it trends downwards. The quality compressions continue to trend downward too. They're just not even doing any job. They're not doing anything. We're not moving blood. We're just wasting our time. If we can get that person to hit that 100 to 120 rate at the proper depth, we can continue that perfusion cycle, especially when we drop an IGL on my end. If you guys get there and need to change it, I understand, depending on your protocol. However, we're not interrupting that CPR. If it's still working, if it's still ventilating properly, if we still got good breath sounds, we get good capillary refill, or maybe even a blood pressure, possibly with a rescue pod, you may consider leaving it alone. That keeps you on the chest some more. Taking its sweet time rebooting. I had at least a good 5 or 6 minutes, not 30 seconds worth of battery life. Yeah, it's fired back up. Now it's just going to have to reset see itself. So again, I apologize. A little technical difficulty this morning. We got video now too. Okay, man, we're rocking and rolling. This is the one password I actually have to remember. Everything else is saved in there. Does anybody else use the same password? Just add a number to it and change the number. Yes, and then you get 3 opportunities, so you have to guess. I think it was this one. Maybe it was the one before. Maybe it was the one after. Yeah. All right, let's get this thing back open again. I apologize. All right, let's pick this one for. No, I don't want to open Microsoft Teams and everything else. All right, so let's look at this one again. So these reports go out to our crews. We have this line right here, that top bar. That's our 2 to 2.4 inches compression depth, and that's going to record every compression in there. This crew right here, Rescue 4 on 324, are just freaking rock stars. They're a little fast. I will absolutely give you that. But depth-wise, they're doing really, really, really well. What the computer itself in the program, it looks for a compression that's in depth, that's in rate, and it gives you a compression in target. So that's why that matrix right there is actually empty, because the vast majority of those compressions were too fast. And that's typically what we see, right? Because everybody's kind of amped up and keyed, and they're just, you look down and, I'm sure, back in the day, you're riding the cot, your hair is blowing in the, when I had hair, it was blowing in the wind as you're going into the ER, right? Because you're superstars. Golly. Thank you. Yeah, well, it's just it's opening everything up over as I just opened the machine. But we did crappy CPR. I'd hate to see these reports from when I was actually on a bus, but still. So we have our rate. This rate right here, this is the auto pulse. The auto pulse runs at that 80 intrinsic rate. That's where it takes over. The machine recognizes it. That's its depth. That's its rate. I know it doesn't look like a lot, but it's doing a circumferential compression, so it's supposed to be a better compression. Release velocity. Release velocity, I love these trends. Can you see the trend? Every one of them starts high, ends low. Starts high, ends low. High to low. Those are 2-minute cycles, because once that machine is in AED mode, which is where we typically leave it, and of course once you exit that, you still have the 2-minute counter. At 2 minutes, I don't care who you are and what you look like, your CPR is suffering. And this is why we have to rotate. Those guys, no, I'm good, I'm good. No, move. Next. And we talk about that next guy right there beside him. You should be able to trade off. One guy comes off the chest, next guy comes right back on the chest. It's time on chest, time on chest, time on chest. So again, this is one of the report cards. We have a couple other matrix also. You know what that is. That go along with that, and this is kind of the bottom of that screen. It gives us a compression fracture. It gives us the manual depth variability. We had 55% in target. We had 42% in target. I know that sounds horrible. You're talking, in millimeters, so it can be sometimes a difficult target to hit. And that, since the new AHA update, it's really small. Time off chest, CPR pauses right here. We want to see everything under that 10-second mark. This is pretty good. We had 3 pauses at 10.6 and 8.3 and 7.41 seconds. The greatest pauses we see is the switch to the auto pulse. And this is where we don't own an auto pulse. We have an old dead one that we used to train with. But coordinate your efforts with that machine, because having it laid out, having the straps flip back, having it all set up and ready, already turned on, is the key to maintaining that 10-second, because I've seen them at 18, 20, 30 seconds. And you can totally tell, because the next set of compressions are at 80. That's where they put the auto pulse on. They just get off the chest and everybody's moving around. The last guy that should release at the end of that 2 minutes should be that compressor up on and get that strap right back on me to compressing. Then we can put the straps on, then we can adjust them as we need to. We got to get that machine running again. So just be cognizant of that. That's kind of the worst thing I've seen as far as time off of chest, excuse me, or intubation. No shots, but some people are just a hard tube. So again, I mean, we was trying to see if we had a really, and of course, I guess everybody knows that the machine itself actually records in real time. I don't think I have it in the STEMI reports. Let's see your video. And we'll send this video out. This guy didn't do too hot. He went to AFib. They shocked this guy. They actually got him back. And you'll see a conversion eventually. And I like to catch these when we have a conversion. But again, we use these as QA points to try to help our crews do a little bit better. I'm showing you some ones that are just kind of a little bit off.
So have you noticed a big difference having this data showing it to the person?
What I've noticed is the guys, typically what's happened is the guys will call me, hey, we just ran a code, we'd like to know what happened. Absolutely. So I'll start the email train of, because sometimes it's 2 to 3 days before we know the outcome, depending on if they're, to see the ICU, if they're in hypothermic therapy or whatever. Sometimes it's 2 weeks because they've set. in CVICU. So we just kind of track those down. We pass that information out. We get this out to our crews, and they review it. They'll go over it because they know they can tell you exactly who this guy was, because they were there, right? I know I did compressions the second time, and I did compressions the third time. This guy's a little bit deep. Man, he's spot on in release velocity and rate. So, those are pretty high quality compressions. This has changed our game. I mean, this guy right here I'm not sure who this guy was on ladder one, but this guy's kind of a rock star. Honestly, yeah. So anyway, that's where we're at. That's where we're headed. And again, we want to make sure that we set you guys up for success. So when you roll in the door, you can run off your check sheet. I don't have to worry about this. I don't have to worry about this, because you have a million things running together in your head. Previously I worked at Carthage Fire for several years, but I did all my time as an ALS down in the Tulsa area. So I was a paramedic with Broken Arrow Fire. We were spoiled. We would show up with literally 3 paramedics to every code off of a 5-man company. And the paramedic that was running the code, like they do in the videos, you're like, that never happens. He stands there with the book and says, okay, I want you to intubate, you start an IV. That's literally how we would run a code. And it was awesome, but that just doesn't happen here. That paramedic is doing everything. You've got 100 things going. So the more things we can pull off your plate, the better the outcome's going to be for that patient. All right, so that's what I had to fill in for until we hit lunchtime. Does anybody have any questions? Thoughts, questions, concerns? I know my guys are just, man, we want to say something. I can tell. Not at all. Not at all. Yeah, if you guys ever need anything, obviously, on our side, from anything from, I hope we've conveyed that. You need a driver, you need somebody to go with you, whatever you need, we're there to make sure patient outcomes are successful. We'll figure it out after the call. We'll do whatever we need to do to help you. And then, after the call, we may have to move people around to go catch a truck or do whatever else. We'll do that too. That's what we're here for. So, all right, well, that's what I have. Mr. Prosper, we're going to break for lunch, I believe.
I'll say like 3 words, basically.
Oh, perfect.
So just to sort of tie into the cardiac arrest thing that Dustin just talked about is the new Heart Association guidelines. They change every 5 years-ish. So the new guidelines for 2020 just came out. It was 2 weeks ago, October 21st. The good thing is there were not major super significant changes in those. They added a couple of drugs to be equal. Lidocaine and amiodarone are basically now the same. Sorry, right there. A couple of things to simplify. So it's not a huge major change in new ACLS guidelines. I haven't actually seen them out yet. We got our little preview, our update class, which seemed a little small, actually. It was like that. There wasn't all that much there. But it did explain a few things, like lidocaine being equal to amiodarone, epi going from every 3 to 5 minutes to every 4 minutes, so that it ties in with your 2-minute cycle of compressing. So every other time you switch, like he was just showing you there, every time you switch compressors, every other time you would get epi when it's appropriate. So instead of having to remember, has it been 5 minutes or whatever, 3 minutes, it's too early, it's just do it every 4 minutes or every other time you switch. There's a little bit of emphasis kind of put back towards your pit crew approach in that so if you're really having someone stand there and watch everything and watch the timer, that when you have that 2-minute timer, someone's watching that never happens, I know. In the real perfect world, if someone were watching a 2-minute timer, at 1 minute 45 seconds, you would start to count down that last 15 seconds and even charge the defibrillator if it's shockable, of course. Charge it so that actually at 2 minutes, you make that switch of a compressing person. And if it's shockable, it's already ready to go. All you got to do is hit, deliver shock. So it's cutting down time.
That's something when you're done, I have a point for.
Kind of tying in a little bit with some of the newer Zoll technology of that AED being kind of ready, because it can see behind the scenes in an AED mode before you really get a chance to look at it, with the trained eye. AED might be sitting there already kind of knowing what needs to happen next, so it can actually pre-charge itself. And kind of tying into some of that same guideline. No major changes that I remember from BLS, really.
The shocking was different. They want you to hover like that far away from the patient.
Oh yeah, when you stop, hover. That way, it's all about minimizing the interruptions of the chest compression. That's the most important thing in any CPR Heart Association conversation about compressions and stuff. Is minimize compressions. A lot of those things were all directed towards that. You remember anything else, guys?
As far as cardiac arrest, no, there were some changes to the bradycardic
Oh, give epi sooner.
atropine was 1 milligram instead of half. IV before IO.
Interestingly enough, Dr. Finley earlier mentioned about going IO over IV, sometimes just skipping IV, not even trying. So the new AHA guidelines really want you to get a peripheral IV first. They really, I thought they were kind of like earlier. I said I thought the state was going to do one thing. Our association actually is wanting an IV, a peripheral IV stick. Their preference. I remember that.
Yeah, IV above the waist.
IV above the waist. So from that guideline standpoint, your habit that we've all formed, probably you guys are formed, of going straight to IO is kind of in the eyes of that guideline, not really correct. But how you actually practice that in the world and how you document it, that sort of thing. But that's what the guideline is going to say. It'll say prefer. It's not going to kind of switch. Give you that coverage. The guideline that says, IO is okay to start first. It's still going to say peripheral IV above the waist.
A couple things on that same topic, and I forgot to bring up, is that we're a part of a clinical trial for Zoll, and our X series have some trial software that's installed of it. It's called Pre-Shock. While they're in AED mode, which it doesn't do it when they're in manual mode, just so you know, when you switch it into manual mode, it's kind of void. But while it's in AED mode, it is using that see-through CPR feature, and it is looking behind the scenes to see what the rhythm is as you're doing CPR. If it realizes or if it sees a shockable rhythm, it sees that VFib, it's going to pre-charge. It does it behind the scenes. You don't hear it ramp up. You don't see the light flash, nothing, but it will pre-charge the capacitors. And it's looking at that 2-minute mark. So the second you pull off the chest at 2 minutes, it will say shock advised. It won't even see, it'll do a quick analyze. What it does is for a Zoll to shock, it has to have a 3 positives. It has to analyze yes, analyze yes, analyze yes in the AD mode, and it will allow you to shock the patient as an EMT provider. However, with pre-shock, it will do the first 2 checks behind the scenes as you're doing CPR. When you pull off the chest, it does the third check. It's already charged, and you can hit shock. In our practicing and training with it, we're doing somewhere between 5 to 6 seconds. Instead of, before you would sit there with AED and you're like, oh my gosh, this is an eternity. Because it does, right? Time stands still when you're waiting for an AED to analyze, if you've ever been there. So that's something that we found works really, real well as far as minimizing time off the chest when we're working that call. I know a lot of our paramedic providers, while they're doing other things, if they're still there kind of working on their own or they're still working things around, they'll leave in AED mode and let the EMT run that because it runs really well on itself and it will pre-charge like that until they get their IV and some other things set, and then they'll take back over and where they can have more of an overview instead of being married to the monitor. So it's food for thought. If you do want to use something like that, the AED also has a piece of software installed that's called, I forgot the name of it, but what it does is the AHA found that in VFib, if you can get that really good CPR for some time, and typically it's 2 rounds of CPR is what they're saying right now. Again, it's clinical trials, but it'll shock the first time. The second time it sees VFib, it won't shock it. It'll allow you to do another round of CPR before it shocks it again. And the theory behind it, again, it's why it's a clinical trial, is that if we can get the perfusion to the heart, we can get the cardiac tissue really well perfused before we zap it, that it's more likely to return to a normal rhythm. So that's a couple things that we have on our side that you may have use of or utilize, but just kind of so know that that's out there, and that's kind of what we're doing in lines with that. So.
All I had is chapter 11, so go ahead and take lunch. We'll start back at noon. A little under an hour.
Okay. Is this thing still on? Okay, so for those on the internet, we're going to start back at noon. We're going to take an hour lunch.